FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast Vascular, direto do Congresso Science 2024. A gente está recebendo o Dr. Luiz Leon, que é um grande cirurgião endovascular do Arizona, nos Estados Unidos, que realiza inúmeros procedimentos endovasculares, dentre eles a abordagem carotídea pelo pescoço, o TCAR, e ele vai nos contar aqui a possibilidade que existe de você realizar um TCAR sem o dispositivo dedicado. Luiz, we are very welcome here. It's a pleasure to receive you in our podcast.
Thank you, Arthur. Pleasure to be always in São Paulo. It's been a little while since I haven't been here, so it's wonderful to be back. Thank you.
So we are discussing about the opportunity and the possibility to do the carotid treatment without the specific device for TCAR. Do you think that is a real possibility to do that?
Yeah, I've been thinking about that for a little while because, as you know, I was born in Peru, and I still keep my ties with South America, with Peru and Brazil and Argentina. And so I've been using TCAR since its inception. It came up in 2015, so it's a 9-year-old technique. And I know people that work for the company, and my interest has been always in the outside U.S. market. And so I've always tried to bring not only knowledge but technology and apply what we have in the U.S. to my countrymen, so to speak, and my region men, so people in South America. And so in those lines, I thought that TCAR is one of the things that, in my humble opinion, you don't need the device and you don't need to pay that much money, because the flow reversal that you do with TCAR is done by applying a clamp in the common carotid and by putting an arterial and a venous sheath connected to tubing. So the materials that you need to perform the TCAR, in my opinion, and I don't know, maybe engineers can tell me that I'm crazy, but to me, the materials are simple, and we have them when we do interventions in other territories, like the legs, micropuncture sheets and needles and wires. We have them. We can put a very short A-fringe sheath in the neck, A-fringe regular in the veins, connect with a tubing and create some sort of a filter. Mm-hmm. And I feel that technology will benefit a lot of people without having to have the investment. And I don't want to I don't want to stop the gain from the company, but the company is too small to supply the US and to supply everybody else in the world. I think if they are swallowed by a bigger company, then that will not happen. You won't have that technology here for a while. It happens every day. There's news, with different companies, so it wouldn't surprise me, because to me, now we're in the latest protocol investigation trial we're involved is now roster trial. We're actually enrolling patients. We're applying TCAR to standard risk patients. So in the past, all trials had involved high risk patients, and now we're actually including patients of standard risk, a patient that can have an endarterectomy, and we're showing very good results. So the technology is gaining more popularity because the results are really good. So I suspect that a bigger company is going to find them attractive and buy them at some point.
Sooner or later, it's going to happen.
I agree. Yeah, I think so.
And how to proceed a homemade TCAR, can you call like that? Which device we need here in Brazil? A catheter, the wire, what type?
Yeah, I would say that the filter will be the one thing that is unique, and the stent. And I attended one of the Dr. Cinco's presentations yesterday. He spoke about a dual mesh stent.
C-guard.
That's right, the C-guard. And it had an open cell stent inside with a closed cell outside. So you have the stent with a different company. In fact, the stent we use with TCAR is a first generation stent. Now we have the taper stents, which they were released recently. I haven't used them yet, but the first generation stents for TCAR are single size. So they are 8 millimeters front and distal, 9 or 10 or 11. And so the common carotid is much larger than internal, and so sometimes it's a problem. Now they have taper stents, which haven't used yet. They just released them. But that's the first generation stent, so I feel that you do have the stent already with a different company. The only thing that is unique of the TCAR device is the filter. And so if you come up with an idea of filtering the blood that comes out of the carotid before it goes to the venous, that would be your homemade, poor man's device.
Yeah. I imagine that the real problem is the sheet, I think, because I saw 3 or 4 times you doing the TCAR, and I saw that the sheet, there is some steps that you need to do it with security, and it's totally different that I ever said in my life, the sheet, the specific one.
But in the end, it's nothing but an A-frame sheath. There's no other. It doesn't have any other pieces or parts. The placement is very accurate because the placement you have, as you know, you have to have a 5 or 6 centimeter distance between the axis and the lesion. So if I were to do the first, let's say that we do the first case in Brazil, I would use somebody who has a 10 centimeter lesion, like a far away, a very good case.
An easy one.
Yeah. So you can put a wire enough, deep enough that you can advance a very short sheath. And so the difficulty is when you have a very limited distance, then the sheath placement is difficult. But the sheath itself is nothing but a sheath. So I don't think that will be a limiting factor.
Yeah, and how to do the retrograde flow using the side port of the sheath?
Correct. So what you normally do, you put the A-frame sheath, you have a side port, and then that is connected to the filter has a button that says low and high, which regulates the flow. And so we always go from low to high, and we leave the flowing high. And I don't think that speeds up the flow. I think the pressure differential between the common carotid and the femoral vein is going to drive the flow. So itself, that's right. That's right. So, and I may be speaking out of line now. No, I'm just going to.
Are you allowed to do this in the US or not?
Oh, on our own?
Yes.
I don't know.
Try that for
I don't know.
Never tried.
If you want to go to the jail, probably
yes. No, I don't think we. But think about PMEG, physician-modified endografts. You really get something that industry gives. You remove it out of the sheath. You make your holes and put it back. So I guess we're in an extreme circumstance.
You're going to need a license, but you can have it.
Yeah. Right? I cannot think of any other circumstance where, I mean, I have cat catheters. I have, we have done stuff that you cannot use your imagination to get away with something that you're doing. So I imagine that you could do it, but if something goes wrong, people will say, why didn't you use the TCAR device? I don't know.
Changing a little bit the subject, I really want to ask you about the IVUS in carotid artery, that you saw so many surgeons proceeding IVUS in carotid artery. And when I was in the training with Fabio included, he was my, I don't know how to say that, my chief residence could be?
Maybe, yes.
The discussion was to predilatate or not the carotid because it's too much for the vessel. And now we are putting and taking it off the IVUS so many times. So before the stent. So are you using the IVUS before the stent?
No, it's an interesting question because yesterday I saw Dr. Leonardo Lucas presented the use of IVUS in carotids. And so from my first 12 cases, and I remember it's been a number of years now, but my first 12 cases I use IVUS. And the reason being, let me go to the legs for a second. In the legs, I'm very particular about using the one stent, that's the superior stent from Abbott. And the superior stent, you have to size it 1-to-1 with the artery because the idea is you don't want to oversize the stents because that creates chronic inflammation and they restenoze more often. And so I really believe the concept that you have to put a size 1-to-1 to the arteries. In the carotid, when I went to training, I was concerned that the sizes are not many, meaning that they give you stents that are 8 and 9 and you don't have any options. And the carotids are very different in sizes. So I thought the same thing. If I put too large of a stent in a very small artery, I'm going to cause problems in the future. Not having done many, my first 12 I use IVUS. And I had a safety that if the patient has flow reversal, I wasn't afraid of using the IVUS up and down because the flow is coming out. That's why I told Dr. Lucas yesterday, if I'm doing a transfemoral stent, I'll be a little more worried, even though you have a filter of moving stuff because the flow is still going up. And I'll be afraid if maybe it goes by the filter. With TCAR, I was more confident of doing. And in the end, we found differences. Size by IVUS and size by CAT scan, there were different measurements. But we put this 8, 9, and 10, and I don't remember having a major problem with these stents. I mean, they seem to work in the carotid. In the leg, once again, making the comparison in the leg, the disease is so diffuse. Sometimes it goes all the way. In the carotid, it's almost always very focal, as you know. So now when you do an arterectomy, above and below is clean. You just have the chunk. So I think it's less critical. Now, his point was you learn a lot of virtual histology. You can do studies. It's like pathology, but with IVUS, because you can see the type of plaque, and we can learn a lot of things of the disease process. And that's commendable and that's good. But for us interventionists, I don't think it makes a difference in the carotid to use IVUS. That's just my point. Yeah.
And last year we discussed about TCAR with Dr. Malgor here, and I did a question for him that time that I will do now for you. Do you see in the future we are using atherectomy in the carotid artery?
Again, it might happen. I just don't think there's a need. Once again, the stents, once you pre-dilate the stents, they expand quite nicely. Once again, the risk is too high, and the results are so good. I mean, the stroke rate with TCAR or carotid endarterectomy is 1% or less. So I don't think you have to. Why complicate something that is already so good? I don't see the need of. It's the same as in the iliacs. We don't use atherectomy in the iliacs routinely. There's no code for atherectomy in the iliacs. The stents work very well in that area.
Perform very well.
Yeah, and they're the same. These stents in the iliacs are A9s. This is also a very big stent, so I don't think you need to debulk.
The only thing it would be the cost.
That you add exactly.
The risk.
And about shockwave?
So very interesting.
I think it's the same because the stent itself performs very well in the carotid arteries.
Yeah, but that's a little different because the contraindication to use TCAR in calcification is 4 millimeter thickness or more. And let me tell you an example. So yesterday, Dr. Sikalas presented here shockwave, and he asked me if I use it. And as you know, Arthur, my practice is 90% plus in the office. So in the office, we pay the supplies that we use. And so shockwave is prohibitive. It's too expensive, and there's no code for reimbursement. So I haven't used much shockwave except in the hospital. In the hospital, I use it in the aorta when I put endografts in very small iliacs. We shockwave the iliac so the device can go up. And the other case, I had a very interesting case. A 67-year-old man was having active angina, and he was sent to the cardiologist. He said, there's too much disease. He needs a 4-vessel CABG. The cardiothoracic surgeon saw him and says, no, he's too sick to have. He sent him back to the cardiologist. The cardiologist put one stent, and then he says, this is the best we can do for him. And he was having active TIAs for the last 3 months. Wow. And so we have symptomatic carotid with symptomatic CAD and a 6 millimeter calcification circumferential of the carotid. So he couldn't be done with a CA because I usually do them with general anesthetic. He couldn't have general anesthesia. So we had to do a TCAR under local. And in that case, I had to use shockwave to break the calcium so the stent can expand. And it worked beautifully. So once again, with flow reversal, you're a little more safe.
Confident, right?
Absolutely. And the technique is beautiful. I mean, this is like the way I've been explaining the technique is like temper glass in your shower. You have the glass. If you crack the glass, 1 million pieces don't fly. They just crack.
Yes,
it's the same. You crack the calcium, so it doesn't really break and goes anywhere.
Did you stop at all doing the transfemoral approach?
No, ever since TCAR in the last 9 years, I may have done 2 or 3 cases, and those are I mentioned one yesterday in my talk. This patient had a radical neck dissection for head and neck cancer, and so the whole thing was destroyed and scarred, even including this area and radiation as well. So I went with from the groin, but very selected cases, open tracheostomies that are constantly draining. You can infect your area. So, but far and few in between. But what's sad is there's other specialties that continue to do transfemoral. When you have a better technique proven, it's half the risk of death and stroke, but yet they want to persist doing it because that's all they can do, and that's to me not good.
And to finish our interview, what do you think about the robotic and endovascular surgery in the future?
Yeah, so remember we had the chance to go. Arthur and I attended a course in Houston. I was very excited, but again, I'm not sure it's applicable at this point in our lives. I think maybe in another 10 years. I haven't heard any other courses or attempts or anything like that.
They stopped the operation here in Latin America.
Oh, really?
Corindos is not here anymore.
Oh, wow.
Yeah.
And it was interesting because they were actually trying to, because the reps that hosted us in Houston, they approached us after to say, listen, you can even buy the robot just for marketing. If you put the robot in your office, people will say, oh, these people are up to date with their device. Not necessarily to use it, but just to...
It's a very
take some pictures.
In Brazil, it would
work very well. Put it on Instagram, Dr. Luis.
That's right.
Thank you very much for your interview,
guys.
for your time.
Always a pleasure.
It's a pleasure to receive you here.
Thank you, Arthur.
Não deixe de continuar acompanhando os episódios do FRêMITO Podcast Vascular, direto do Congresso Science 2024.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.